and then I'll just drop off when my portion is done.
Okay, sure.
All right.
Sounds great. Good morning, everybody. Thank you so much for being with us this morning. It's great to see so many of you. We would love to see your faces, even if you haven't finished your first cup of coffee yet. I understand, believe me. But we are going to go ahead and get started. It is 9 o'clock, and we have quite a few things to get through today. So we're going to jump right in. We have the exciting privilege of Louis Morrow joining us this morning for the first part of our program as our guest speaker. And Louis is with the Intelligent Retinal Imaging System, or IRIS. He and I connected recently at the USA-Canada Lions Leadership Forum, and I heard one of his seminars there and was really excited by the work that they're doing at IRIS, really encouraged by his words, and thought that he would have something that you all might want to hear. Maybe even something that you might want to buy from him, which I'm sure he'll talk to you a little bit about today as well. So without any further ado, again, Louis is Vice President of Sales at the Intelligent Retinal Imaging System. He's been one of the earliest leaders at IRIS, been with the company since 2015, and has contributed significantly to the growth of IRIS through numerous newly developed partnerships that he's built with major health systems and IDNs across the country. Again, I think he's going to offer a really unique perspective for us this morning. So Louis, I'll turn it over to you. Thank you for being with us.
Yeah, thank you, Daniel. Appreciate you including me here this morning. Morning, folks. Look, I'll get it out of the way right now. Yes, these are Alabama posters over my shoulders. For those who might be South Carolina or Clemson fans, I don't know if that gets me any points or not, but I'll just throw it out there.
I don't know.
I'm sure you noticed them right out of the gate. I'm actually located in Nashville, Tennessee. Our company is located in the Panhandle of Florida, in Pensacola. I grew up in Alabama and have spent some time in various other places. And I'm really excited to talk to you guys today. As Daniel mentioned, he and I met, I guess about a month ago in Reno at the USA.
What is she asking?
I'm sorry, is there a question?
Oh, you're good, Louis.
Oh, okay, sure. And, you know, I have gotten to know various Lions clubs and organizations over the past number of years, but in particular, there's a growing relationship and partnership with the California Lions Foundation. So, of course, the other coast from where you guys are. And that's really what led me to start to get involved in the organization and really be there in Reno and present, as Daniel mentioned, one of the seminars there. It's been a really gratifying relationship so far because of the work that Lions do, clearly a focus on protection of vision. And there's a lot of similarities in the missions between my company, IRIS, and the Lions, and those are pretty evident, right, with the things that you guys have done for generations. I'm going to spend some time talking to you today about really what we do and how those missions align. I'll talk to you about some impact. There's some really interesting new developments in my world having to do with artificial intelligence, which is one of those buzzwords that's out there a lot, particularly in healthcare. So we'll talk a little bit about AI and how that relates to our world, and we'll talk a little bit about some of the existing relationships and partnerships that we have with other clubs across the country. So let me start to share my screen here. I got some slides to show you guys. Daniel, everything check out? Still look good here with what I'm showing you? Okay.
Looks good.
All right. So let's first start to kind of talk about this condition of diabetic retinopathy. I'm sure most of the folks on the call today are aware of that disease. You probably also know that it is the number one cause of blindness, really, any way you slice it, in the US, amongst working age adults, amongst adults in general. It is the leading cause of blindness. So the disease that we're trying to identify, again, is called diabetic retinopathy. And there's various stages of diabetic retinopathy. On one end of the spectrum, there's a mild diabetic retinopathy, which might not even affect your vision. If you are a diabetic and you have mild retinopathy, or even moderate, you might not even know it. It could be asymptomatic in those early stages. But then as it progresses to a more severe or even a proliferative, that's where it starts to have impact on your vision. And it's that continuum that has really caused this disease state to be the leading cause of blindness, because it's this sort of compounding effect, right? We all know the epidemic of diabetes in the US today. And you see the numbers in front of you. Let's just use some nice, easy round numbers here. All right. So there's roughly 40 million diabetics. I know it says 37, but let's factor in probably some pre-diabetics and the rate that this is growing. Let's call it 40 million diabetics. And if you're a diabetic, maybe some of you on this call are, you have been instructed by your caregivers to get an annual diabetic eye exam. And that is because of what I shared with you a second ago, because there is a downstream effect of having diabetes, and it affects your eyes. It affects a lot of your extremities, of course, but it has a particular effect on your eyes and your vision. And if those diabetics were to get their eyes checked like they're supposed to every year, I think we would have a much better control of this condition called diabetic retinopathy. The unfortunate thing about this whole situation is really less than half, and the number here you see, it's about 40%. Less than half of diabetics in the US are getting their eyes checked on an annual basis like they should be doing. And there's a lot of reasons for that, right? It's not just simply that they're defiant and they've dug their heels in. There's some really legitimate reasons and barriers why these diabetics have not or don't get their eyes checked once a year. One reason is quite simply access. There may not be a lot of ophthalmologists or eye care professionals in a rural setting where many of these diabetics live. Certainly, there's an education component here. Some folks, some diabetics think, oh, well, I just went to Walmart. I just got my new glasses. So that's my eye exam. I'm good for another year. Well, that's not what this exam is, right? This is a very different exam. That's more of a vision check. And this exam, this diabetic eye exam, is more looking at the back of the eye, the retina, which is where the damage occurs here. Sometimes clearly there's a financial component to that in terms of being properly insured, uninsured, underinsured, depending on the part of the country that you're in. There's certainly an undocumented population that's out there. So there's a lot of demographic and financial elements as to why diabetics don't get their eyes checked like they should. And so really that's how we kind of came about. Is the historical model was, if you're diabetic, you ask the diabetic to go to the test, right? So go to an ophthalmologist, go to an optometrist, go to an eye care professional, which means you're taking another day off work. You're probably having to pay a copay. If we can get past all the barriers that I just laid out to you, access, financial, all those other things, then maybe that diabetic does what you've asked them to do if you're their primary care doc and they go do that. But the reality is, as you see in front of you, less than half actually do. Okay. So about a decade ago, a little bit longer in some instances, that model was sort of turned on its head. Okay. And instead of asking the diabetic to go to the test and encounter all of those potential barriers, because of some advancements in technology, we've now developed a way to bring the test to the diabetic in a number of different environments. Probably the most common is moving that test forward into a primary care environment. So no longer does that diabetic have to go see an eye care professional, an ophthalmologist or optometrist. Now, because of those advancements in technology, which we'll get into in a second, this test can be done in a primary care environment. And it's proven, it's documented that the diabetic is much more likely on a very regular basis to go see their primary care doctor than they are to go see their eye care professional. So we've reduced one of those barriers by moving it forward. This test can not only, though, be conducted in a primary care environment, you can really do it anywhere. So in our minds as an organization, we've thought, let's take this test to where the diabetic is. And yes, they are in their primary care doctor's office, but guess what? They're also in a lot of other places. They're at home. This test can be brought directly into a diabetic's home. They go to work. This test can be done through part of a workplace health type of program. Or diabetics are going somewhere to do something, right? So think if they're going to Walmart or CVS or the grocery store, any other retail environment, this test can be done in a retail environment. So our goal, our mission is to end this epidemic of preventable blindness by creating much better access to this quite simple. It's a pretty simple test. The exam itself is pretty simple and pretty easy to conduct. It's all the other issues that have prevented it historically that's really led to the fact that retinopathy is the leading cause of blindness. Okay, so that's sort of the background. And here's some of the reasons, again, why folks have considered adopting this new model. Remember, we've kind of turned it on its head. Instead of asking the patient to go to the test, we are now bringing the test to the patient. And it accomplishes these things. Not only have we increased access, we're taking to the test where the diabetic is, but we've also certainly improved the quality of that care because we're identifying this disease earlier. And like a lot of other issues in healthcare, earlier detection leads to better outcomes. Okay, certainly is the case with the treatments available for diabetic retinopathy. If we can also identify it earlier, not only can we prevent vision loss, but from a healthcare dollar standpoint, we have absolutely reduced the cost of care, because while there are treatments and therapies available for diabetics who've been diagnosed with retinopathy, the further along the spectrum that patient is, so if they're moderate, severe, or even proliferative, the more expensive those treatments become. And again, that's not that different from any other disease state, but it's certainly documented amongst the treatment of diabetic retinopathies. And if you're a health system, which some of you may or may not be, I'm not entirely sure the makeup of the audience, but if you're a health system, there is a little bit of revenue associated with conducting these exams. But as you see, that's really last on the list. Most importantly, it's the ability to meet that diabetic where they are, offer access to this test, and ultimately identify the disease early, which helps you preserve eyesight, which again, for us, I think there's a great alignment with the Lions, not only there in South Carolina, but really all over the world. Here's what I was referring to when it comes to cost avoidance. Okay, so that's this idea of early detection helps open up more affordable therapies. And so here are images you can see of the various stages of retinopathy. And I guess just to take a half a step back, how retinopathy shows up, these are images of retinas, the back of your eye. And retinopathy is essentially disease or damage on that retina, on the back of the eye. And if left unchecked or untreated, it will continue to grow and proliferate. These are small bleeds, microhemorrhages. There's a element of this that's called neovascularization, where new blood vessels grow to bypass the damaged blood vessels. And all of that is, I'm not a doctor, but let me just break it down for you. That's not good, okay? If that were to happen in the back of your eye, and that's what leads to vision loss, because it affects your optic nerve, which is that bright white circle there that you see in these images. And ultimately, that's what leads to this disease state being the leading cause of blindness. But if we can catch it early, so on the left-hand side of your screen, you see the normals and even the milds with not a lot of damage, then therapies and treatments that are available to that, even for mild retinopathy, we probably just want to watch that. If you're an eye care professional, watch, re-image, monitor that on a regular basis. As you get into the more moderate, severe, and proliferative, then you've got some pretty significant damage. And the clinical approaches to treating those can get pretty expensive. So if you're a health system, if you're an insurance company, if you're an accountable care organization, if you're a Medicare Advantage plan, you really care about cost avoidance, about identifying this early, not only because you want to help your member or your patient, but if we can catch it sooner, then we can save some healthcare dollars along the way. Okay. So let me tell you a little bit about us. I mentioned we've been doing this for about 10 years, and there's a couple of milestones that we've recently hit that we're particularly proud of. The stuff on the top is kind of relevant if you're a healthcare system, but let me draw your attention to some of the numbers along the bottom of the screen here. So we are now approaching, we'll easily hit this number by the end of the year, 1.2 million diabetic eye exams that we've conducted through our various partnerships in our existence. All right, so that's a really important. We hit 1 million in January. Okay, so we're ticking along in terms of the lives that we've affected and the disease that we've helped identify, and ultimately the number of diabetics who we have preserved their eyesight. So statistically, if you look at the numbers across the bottom, we've done about 1.2 million exams. The next number is the number of instances where we've found some type of pathology. Okay, so again, simple math. Remember, I went to Alabama, so I'm going to keep the math simple. About a third of all of these exams have come back with some type of pathology. Okay, that's kind of a striking number, that a third of all diabetic eye exams that we've helped conduct with our partners come back with some kind of eye disease. Now, it's not all retinopathy. That's the next number, 208,000. Those are confirmed diagnosed retinopathy patients. So in that case, it's about 20%, right? But a third of all patients come back with some kind of referable disease or pathology. And so let me explain the difference there. Of course, the 20% or so that's diabetic, those are mild, moderate, severe, or proliferative diagnoses of retinopathy. Okay. The 362,000, we're going to add to that other suspected conditions, which the ophthalmologist who's interpreting these images can suspect other things, which are also kind of common and typically found amongst that diabetic population. So think glaucoma, cataracts, wet or dry macular degeneration, hypertensive retinopathy. There's a number of other conditions that could be present in that diabetic patient that may not necessarily be retinopathy, but that can also affect their eyesight. Okay, so because we've got an ophthalmologist on the other end who's looking at these exams, that ophthalmologist is going to be able to identify those other suspected conditions. But the number that we are the most proud of, this is what keeps us going, is the number on the far right. And that's an internal term that we've coined that we call an iris save. Okay, and a save is quite simply disease that's been identified that is on the far end of the spectrum, that if left unchecked and untreated, it will lead to vision loss. So in other words, we've saved the eyesight of about 10% of all of the exams that we've conducted. About 10% of the time, that's a patient. And remember what I said earlier, in many instances, they don't even know that they have this disease because up to a certain point, it's asymptomatic, right? So about 10% of the time, we've helped a patient not only be diagnosed, but then assuming the next appropriate steps are followed in terms of a referral and treatment plan, we've helped to prevent vision loss with that. And that's That's a significant number for us. We track that number internally. We celebrate that number. We share it at company meetings. That is our mission, to help end preventable blindness. And we do that by identifying the not only all pathology, but certainly in the case of the 147,000 saves, that's the worst of the worst. Okay, if you want to think about it that way. So we're really proud of the impact that we've had. The unfortunate part of all of this is, remember what I said in the beginning, there's 40 million diabetics in the US, and only less than half of them are getting their eyes checked. We've examined 1.2 million. There are millions of other diabetics that are still slipping between the cracks here, that are still not getting their eyes examined, despite everyone's best efforts. There's still a lot of diabetics that need our help, and need a lot of other help from other folks too. Okay, so that's how we're continuing to pursue this. In a nutshell, I told you that we've turned the old model upside down. And instead of asking the diabetic to go to the test or go to their eye care professional, we're flipping that around and we're bringing the test to the diabetic. A big technology development that has led to programs like ours, and why we can do this, is advancements in the hardware, in the cameras that are used to capture these images of the back of the eye. Used to be, and these are, well, let me rephrase that. There are really two types of devices that are out there. And if any of you are in any eye care related professions, you are very familiar with these devices. We put them in two categories. One is called a tabletop device, and one is called a handheld device. And it used to be that tabletops were really the only kind, and they're really still, in the eye care world, they're really very much still the gold standard. They are very reliable, very user-friendly, take high-quality images. Most of them are very automated, which means that the person who's actually taking the picture doesn't have to do a lot of work. They're really, really great devices. But those devices you can't take into someone's home. Those devices might intimidate a primary care physician. Those devices, a pharmacist at Walmart is not going to be comfortable using those. So the hardware side of this has really progressed to where now most of our clients are using a small, lightweight device that's the size and shape of a hairdryer, that fits in your hand, that's about 2 pounds, and can be put in a car and driven around to diabetics' homes. So that's a significant development, and a big part of why we can do what we do, because those devices have come a long way. So essentially what we've done is we've equipped our clients with a device. And there's a lot of different devices out there, even amongst that handheld world. We train our clients how to use that device and how to capture that image. And really quickly, most of the clients that we work with have chosen devices that are called non-mydriatic, which means no dilation drops are required, which, if you go back to the beginning, that's also another barrier why diabetics have avoided getting this eye exam in an eye care office, is because they're nervous about getting their eyes dilated. And if any of you have had a fully dilated comprehensive eye exam, you know exactly what I'm talking about. It's just weird that you get your eyes and you have to be careful with the sunglasses and driving and all of those issues. These devices, another advancement in the hardware and the cameras, is that most of them don't require dilation. Okay, so we place the device, we train the users on the device, those images are captured, and then with a click of a button, they're sent to our platform, which is a cloud-based platform. On the other side of those images, we have relationships with eye care professionals all across the country. All right, so we operate in all 50 states. We've got licensed eye care providers in all 50 states, and they are remotely accessing those images and performing a thorough diagnostic review and evaluation of those images. I showed you an example of that a few minutes ago. As they are reviewing, they are looking for signs, symptoms, markers, cues for this disease state, diabetic retinopathy, but they're also looking for all of those other conditions that I shared with you a second ago. They are then compiling their findings using our platform and our technology to do that. And then that is put into a final result report. It's usually about a 1-page PDF file with all of the findings and even recommendations for the next step based on the severity of the findings. And then that result is sent back to the originating or the ordering provider. In many cases, it's a primary care doc, but in other cases, there's other relationships there, okay? So think of those easy 5 steps. There's a camera. We're going to teach someone how to take a picture. They're going to take that picture. They're going to send it to us. Our ophthalmologists and eye care professionals are going to evaluate that picture. They're going to diagnose findings and send that documentation back to the originating source. It's pretty simple, okay? But it's made possible by the advancements in the hardware and in the cloud-based platform that we've developed that's fully HIPAA compliant, fully secure. Remember, we're sending some pretty sensitive stuff back and forth here with retinal images and patient information, okay?
Louis,
So that's really how it works.
Yeah, Louis, before you move on from that, could you
Sure.
talk a little bit about the turnaround time, assuming that these images are uploaded on the day that they're taken by the vendor? What's the turnaround time?
Yeah, Daniel, great question. Because these are being really reviewed and evaluated by human eye care professionals, it's not an instant result. Okay, and we'll talk about that in a second. I know we're probably running short on time, but we'll talk about the AI piece here. And on top of that, most of the eye care professionals that are working with us are all still practicing physicians. So as they receive these images in their queue on our portal, they're doing these evaluations in between patients during their lunch break, in the mornings over coffee, etc. So with all that being said, we commit to a next business day turnaround, Daniel. So you do the exam today in whatever environment, it gets sent to our physicians. By tomorrow, that result will be back in your hands. And any next steps that are recommended can then commence and begin at that point, okay?
Excellent. We also have a question for you in the chat here. Are
Sure.
you working with free healthcare clinics or community centers such as food banks to get these in their spaces?
So the short answer is we work with everyone. And while, yes, we are a business and, revenue is important to us, we also, because of our mission, understand the importance of breaking down these barriers and helping to create better access to these diabetics. So part of your question, it's a definitive yes. We've worked with federally qualified health centers. We work with community health centers, rural health centers. These are federally and state funded healthcare providers that have underinsured or uninsured type patients that probably more than the average bear need this exam. In terms of food banks and other charitable organizations, not as much, although we are working directly with a number of Lions clubs across the country. So think of the Lions as that type of charitable organization who obviously it's a volunteer-driven organization. Many of them have no medical training or background whatsoever. They come from all different careers and professional backgrounds. So in those cases, we're actually partnering with those folks to provide this service to that person who really, again, needs it probably more so than your typical diabetic. Okay.
Sure. Another question in the chat here. Are there plans to roll this out to those affected by inherited retinal diseases in the future?
So it's really an interesting question there. And part of the answer is dictated by the FDA. Okay. So when we go to get this, when this was founded, when we were created by our founder, who himself is a retinal surgeon, you submit all of this to the FDA, and the FDA gives you, in their language, a clearance, all right, or an approval. And in that approval, you are specifically allowed or approved to do certain things. So our clearance from the FDA allows us to diagnose all these stages of diabetic retinopathy. Okay, so in the eyes of the FDA, that's what we are approved to do. I'm assuming that whoever asked the question, clearly there's an application to this technology that goes beyond diabetic retinopathy, right? I mean, if you've stayed, even in the past 6 to 12 months, the advancements in the ability to diagnose all kinds of other things through retinal imaging is fascinating. Cardiovascular issues can be identified through retinal imaging. Early onset markers of Alzheimer's can be identified through retinal imaging. And that is the next wave of what can happen through this type of program and analyzing retinal photographs. So it's really a two-part answer. What are we cleared by the FDA to do? Diagnose diabetic retinopathy. The capability of programs in general, really the sky's the limit. You've probably heard the eyes, or in our case, the retina, the back of the eye, is absolutely the window to so many other healthcare conditions, and that's coming. And we have had many internal conversations about reapproaching the FDA to expand what we are allowed to or cleared to do. Now, the last part of the answer is the ordering physician. Let's say it's a primary care doc or whoever. That ordering physician can order this exam for any reason. Ultimately, it's the physician's choice to decide why they are ordering this exam. In most cases, it's because the patient's diabetic. But in other instances, maybe the physician says, hey, you know what, we think you're pre-diabetic. We think that there could be a place for this exam because you've got high blood pressure and there might be some hypertensive retinopathy. Maybe it's a cardiovascular thing. Maybe it's an elevated stroke risk. Maybe it's, again, an Alzheimer's thing. There are reasons why a physician might order this test. But it's a bit of a long-winded answer, but I hope that addresses the question.
Awesome. Thank you.
Daniel, I know we're over, and so I'll defer to you.
We can go for a little bit longer if you've got the time. We can go for another 5 minutes or so.
Yeah, so let's jump to, we do work with Prisma, the big player there in your state. They're one of our big clients, and I'm happy to share this with folks that might want to review it. But let's jump to this AI discussion, okay? So right now, again, it's really kind of dictated by the FDA. There are two ways to do this that are currently approved by the FDA in the US. One is the human red model, which that's what I've just described to you. And the other is a newer approach that is it's called fully autonomous, okay? It's a fancy way to say AI. And we know that AI is a big buzzword in healthcare these days. We have the capability of doing both models. So we have a fully autonomous model with an AI result, and we have the human read model with an eye care professional that is interpreting those images. And there are pros and cons to both. Essentially, just like most everything in life, there are trade-offs here, okay? So I'll just walk through the trade-offs, and that's probably about the time that we have to do here. The benefit of the human read is really what you see in the middle here. It is a very robust clinical result, and that's because of not only the ability to diagnose the 4 stages of retinopathy, but all of the other suspected conditions that we talked about. Again, glaucoma, cataracts, hypertensive retinopathy, wet or dry macular degeneration. There's a lot of other things that a human ophthalmologist or eye care professional can identify through the review of this fundus photograph. The AI version cannot do that. It is not allowed or cleared by the FDA to do that. In fact, the AI result will give you one of 3 results. It will either be positive, negative, or the third result is what we call an ungradable, which means the image wasn't that good. Okay, it was a bad picture. So think of that in that trade-off. With an AI, you're simply going to get that you're positive for retinopathy, no severity. We're not going to know if you're moderate or proliferative. It's just going to be positive or negative. Okay. Now there's a benefit to that, right? Because the other trade-off is, Daniel, you asked, what's the turnaround time? With the human, it's about a day. It's a business day. The AI is an instant result. So within seconds, you will get that one of three answers, right? Positive, negative, or ungradable. You will get that result 15 seconds. Okay. So the benefit to that is that diabetic patient is still right in front of you. And so if there is anything, there's a dialogue that can take place in real time to tell that patient, hey, the computer thinks that you've got something going on. You should go see your eye doctor. Okay. The thinking or the thought there with the AI piece is that despite the fact that it's a more narrow result, the immediacy of it might change behavior of a diabetic. Okay. So again, think of the history. For decades, healthcare has been telling diabetics, go see your eye doctor, go see your eye doctor, go see your eye doctor. And less than half the time they do. But in this case, what if I say, go see your eye doctor because we just took a picture of your eye and it says you might have something that could help, that could lead to vision loss. Go see your eye doctor. That's a different conversation, right? That might lead to a change of behavior, and it might make that diabetic a little bit more prone to actually follow through on that referral. Okay. So that's really the key difference, is the depth of the clinical result. Human is much more robust. AI is much more narrow, and the speed. Human is about a day. AI is instant. Okay. Now there are other differences, but just based on time, those are really kind of the key differences on AI versus human. Okay, Daniel.
Sounds great. Thanks. I know we're wrapping up here. Does anybody else have a question for Louis while we have it? Feel free to just take yourself off of mute, or put something in the chat if you'd like to.
We might all be wondering this. So, Louis, I was just curious, your mission really is so closely affiliated with the Lions and what a lot of us are doing to help those that are living in poverty to get the eye care they need. And I was just wondering, typically your organization, of course, works with practices and you're a business, so the revenue is really important. Do you guys ever work with nonprofits on pricing, or do you ever offer any grants or anything? And then that's kind of the first part of my question. And then the second part is the partners you were talking about earlier, when you were presenting the numbers. I think it was like 1.2 or 1.12 or something million people that you've helped. Are those are specifically doctors within practices? They're not necessarily nonprofits or ministries doing these eye exams for free. Is that correct?
Yeah, so I'll address both parts of the question. Do we offer pricing discounts, considering the type of client that we work with? Absolutely. I'll tell you that the handheld camera, that's really the biggest expense, quite honestly, is the device itself. Because of the advancement of that technology, the one that's the size and shape of a hairdryer that I described to you earlier, those compared to what used to only exist in the big, heavy tabletop camera, those are $6,000 to $8,000. Okay, now that's not nothing. I understand that that's still a decent expense, but compared to the older way, those are $20,000, $25,000, $30,000 devices and up. Okay, some of these devices, which don't make sense for what we do, but some of these devices are six-figure, ultra wide field, high impressive quality devices, but aren't really relevant for what we do. Okay, so yes, we are happy to work with you, with any organization, and that's what we've done with other Lions clubs in other parts of the country, is work on pricing discounts and programs that ultimately align with the visions that we've shared. The 1.2 million that you asked about, those are actual diabetic lives that we've touched. Now, how does that start? You're right. Most of the time it comes through a diabetic who, let me scroll up here. I mentioned that we work with Prisma. So let's use Prisma as sort of the way that I would answer this question. So we've worked with Prisma Health there in your state back to when they were Palmetto and Greenville, right? Before they went through that merger. So for a number of years. And the way Prisma uses us is they've used these handheld devices and they are deploying these devices in their primary care centers across the state. So today we're in about 50 primary care locations across the state of South Carolina that are all part of the Prisma network. Okay. So typically, yes, it's a primary care physician that orders those and gets that result. So that's how we accumulate those 1.2 million exams. However, that does include all users, not just the Prismas of the world. So Lions exams that we've done over the years, yes, they're included. Federally qualified healthcare centers, yes, they're included. Our very first client ever was Harris Health System in Metro Houston, Texas, which is one of the largest FQHCs in the country. And we've done tens of thousands of exams for them over the years. So all of those results are aggregated into that 1.2 million. And we can slice it a number of different ways to really identify where the greatest need is and where the greatest benefit has come. Okay, does that answer your question? I'm assuming yes.
Awesome. Any other questions for Louis? All right, well, Louis, thank you so much. If you wouldn't mind sending that presentation over, we'd love to get that out along with the recording from today, both to the folks that were on the call that might want to go back and review something, and to some of our members that weren't able to join us this morning, so they can also hear about the good news of your services and programs. And we'll certainly include your contact information in that as well, if anybody wants to follow up with you about getting one of those devices for their own nonprofit organization.
That sounds great, Daniel. Folks, appreciate you having me. Good luck with the rest of your meeting. And I'll just leave you with a roll tide, maybe? Should I? Or maybe I shouldn't do that. That's pushing it.
Let's end on a good note, Louis. Let's
That's right.
not.
I know. Well, I got it on a high note. All right, folks. Appreciate it. Thank you for inviting me, Daniel.
Thank you so much, Louis. Appreciate it. Bye. All right. We do have a couple other items to work through here. Jessica Garrett is sick this morning from 37 Gears and is not able to join us. 'Tis the season for colds and all those other wonderful things. Make sure you're washing your hands out there. Does anybody have any edits to their organization's Palmetto Vision Alliance webpage that you have not already talked to Jessica or myself about? Okay, fantastic. That is great to hear. Well, we will dive in real quick. Again, we'll review the Palmetto Vision Alliance test website. Just a quick note on that, we are partnering with ABLE South Carolina to do a full accessibility audit of the site as well. That's going to take another couple of weeks to get scheduled and to get finished, but before it goes live to the public, that is going to be fully tested, and some other changes might be made based on the feedback from that. So please know that that is a hyper major focus of our work with this initiative. So when we look at it, let's look at it from the standpoint of aesthetics, design, and factual accuracy of information, rather than the accessibility component, as we'll be getting more guidance on there. And then we'll talk through a couple other quick things related to next year's meetings, and hopefully still wrap up on time. So with that, I hope everyone has had a chance to at least look through the Palmetto Vision Alliance test website. The biggest thing, probably the most obvious thing, is we still have some of these stock images in place, and I know a couple of individuals have been able to send over some pictures from their organizations, so we'll be able to replace some of these with some more local and relevant images. But it's not too late. If you could, in the next couple of days, if your organization has any images that you use for your website or for your marketing that you wouldn't mind sharing for us to use on this, we would love to have more relevant, more local information on it, not just some of the iStock images there. So these header images have not been cropped and set yet, so that's why they look a little off. But the text here will introduce a couple of the main divisions of our missions and how we serve the blind and visually impaired. One of probably the most significant development is this searchable feature for services. So somebody can plug in their zip code and plug in what kind of service they're looking for. If they're looking for eyeglasses, if they're looking for eye tissue, if they're looking for low vision equipment or training, vocational rehabilitation or guide dog support, they can identify what they need and search by their area. So we'll just do eyeglasses and do 29210. And with that search, it will bring up the organizations in that area that provide those services. So that's based on the information that was provided through your responses to our services survey, and they are listed based on geographic proximity to that address. So these will be results from all over the state. In fact, we're going to get down. Yeah, I was going to say we're going to get down to that 29210 is a Columbia zip code, but it will list resources in Spartanburg as well. So there is some sifting out that you have to do, but the first couple of addresses are going to be the ones that are geographically closest to where that individual searched, and there's immediate contact information for phones and websites for folks to link to get in touch with the individuals providing those services. You all. So that's definitely the biggest component of this, and that's taken a lot of programming and building. So play around with that feature a little bit too, and definitely put yourself in the mindset of some of the clients that you've served, or maybe even some client experiences that you've had lately. Try to find the services that you would be looking for if you were trying to get in touch with your organization, and let us know how that's working. Let us know if you encounter issues with that. Could you add assistive technology to? So we would categorize assistive technology under low vision equipment. Tammy, is there a different designation that we should use for that? Please feel free to come off of mute and share some with us.
I think that's fine.
Okay. Should we
Either way.
change low vision equipment to assistive technology? Would that be a better label?
I don't know what the commission would say to that, if they would like to list assistive technology separately.
Mm-hmm.
Because I would think the commission would be listed under there, and then we could be listed under there. Are we listed under low vision equipment now?
Yes. So if we search
okay.
for low vision equipment and go for that same route, ABLE Commission, yep, South Carolina Assistive Technology Program, yep.
Okay, awesome.
Darlene,
and you have our brand new logo.
Yes,
I was wondering if I needed to send you that.
Yep. We were able to get it, and Jessica was able to get it updated. So, and ABVI's new logo as well is on there.
Awesome.
Yeah. Darlene, I saw you on the call earlier. Did you want to weigh in on the label note low vision equipment versus assistive technology?
This is Jeannie. This is Jeannie Farmer with the Association for the Blind and Visually Impaired and what used to be the Vision Institute. I'm kind of with Tammy. Low vision equipment and the provision of low vision equipment in our world is one thing, but technology training is a pretty separate category. So I'd love to see them separated out if possible.
Okay. So have low vision equipment as one and technology training as the other.
That would be my preference. Tammy?
This is Carol from the Commission for the Blind. I agree, wherever we can cross-train, have those references through various, depending on how a person might inquire about a service. So wherever the commission can be, low vision equipment, low vision services would be great. And I'm sure the other agencies feel the same way, because we don't want to miss anyone.
Absolutely.
Yeah. So for us, it would be just assistive technology, I guess, would be the category, because we would, not just do training on devices, we would also do the demos to help the person find the type of assistive technology they would need. So yeah, that's a good point. If we could have us listed under both, if you're doing that, that would be great.
Absolutely. Yeah. So do we need to change the low vision equipment to assistive technology and then add technology training as an additional service provider, and add ABVI commission and vision technology program as providers under that? I see some heads nodding. Okay, perfect. We will do that. We'll get those updates made. All right. Any other suggestions from the service type, from trying to find services you might need? Anybody that spent some time exploring that more? Any other feedback on that component? That's certainly the biggest part of this, and we really want to make sure we get that right. So thank you all for the feedback so we can make those adjustments.
I'm perusing through it. It looks very nice. You guys did a nice job.
Awesome. Sounds great. Moving on down the home page, we have a link to a page specifically to meet the members, and all of you have your own organization specific web page on this. I did notice that there were a couple of changes that had been submitted that weren't quite added to the site yet. So definitely, if Jessica's sick today, she might be a little behind on some of those updates, but definitely keep sending those to us if you've got other changes to make. But I'll showcase ABVI since they've got the new brand and new image and everything up. But when you go to your organization's page, you would see a description of your mission. That's primarily the mission statement that we pulled from your website, so that we can have just a short, succinct description of everybody. We know that there's a lot we can say about all of the amazing work that we're doing, but we're trying to provide only the most succinct and compelling information for somebody that might be needing the services that we provide to learn about us and get connected with us. Addresses for facilities, as well as contact information. That contact information is also really important. I appreciate those that have provided guidance to us on who, there may not be a general information email address or just a general phone number at your organization. There might only be one specific person that things need to be directed to. That's the kind of thing we really need to make sure that we get in here, so that when somebody finds this information, they're able to quickly connect with you and get in touch with who they need for those services. And then it also lists a compilation of all of the services that your organization provides, which when you're searching for services, that's how you'll know if you're going to show up. So again, it's going to be based on the zip code that the potential client uses when they're searching for it, and then based on the services that that you offer on this webpage here. So great information there. Please keep checking those. This is another link to the page to find services in your individual area. We put a little statistic up here about the current prevalence of blindness and vision loss. We did want to feature a couple of projects. We have the Big Data Project. Of course, we all heard from the first phase of that report earlier this year. We have a coalition that kind of came out of this group as a result of our collaboration. Vision for South Carolina is a group of 4 of our members coming together and supported by the Blue Cross Blue Shield of South Carolina Foundation. And then we know we've talked a lot about public policy and about advocacy. We know that's not something that everybody can be involved in, so we've been very cognizant at how we present that on this. We don't want to imply that all of our members are participating in that public policy, because we know for some of you there are very specific and clear restrictions on not being able to be connected with that. So we've really tried to emphasize that this is what specific groups within Palmetto Vision Alliance would be doing. This is not reflective of all members. And we know we don't have a formal advocacy agenda right now as well. So that's one area that's probably going to be fleshed out more over time. It's intentionally kind of vague and ambiguous right now for lots of reasons, but something that we felt needed to be listed on the site. We have a quote from a couple of our members that have come in, so that will be adjusted over time. We'll get a current quote up there, and we would welcome additional quotes. If you haven't sent one in from your organization, we would love to have that. This is something that we can change out and update and highlight in our communications over time. We'd love to know why you're participating in the Palmetto Vision Alliance and what the value is for you. So that's the main page of the site. About Us is going to list more of the objectives and the goals. The special initiatives is going to provide more detailed information about those 3 projects that we looked at before. The resources page is a list of information about vision and eye care. It's a collapsible menu of options, everything from the American Academy of Ophthalmology with a short description and hyperlink to that site, to multiple CDC web pages, Prevent Blindness, and lots of others. Again, are there any resources or links that you all did not see on there that you feel we should add?
Daniel, this is Carol. I noticed that you have the South Carolina Department of Vocational Rehabilitation, but when I click down, it only goes to the general program who serves an array of disabilities, but I do not see the South Carolina Commission for the Blind.
Okay.
As a resource.
Okay, absolutely. We can add that. I'm not sure why that wasn't on the list. Carol, I apologize. Might have been some confusion since y'all are a member and some of these other groups are not. There may have been some confusion there, but we'll definitely add Commission for the Blind as its own resource.
Thank you.
Yeah.
Daniel, is it possible in the future to start to put the free health clinics around the state that do that have eye exams offered?
Yes.
Or am I missing that?
So I don't think free clinics are added under the resources page here. Similarly, we've got the Free Clinic Association, which represents all the free clinics in South Carolina as a member. So I think there might have been some confusion about that with this. I can get the free clinics specifically added here. And then several individual clinics have joined the Alliance as well as members wanting to be more engaged and involved. So we can find out through the association, the South Carolina Free Clinic Association, which of those member clinics provide eye care services. And I agree, I think that would be a useful thing to list there.
Daniel, if we do have edits to our page, did you say that those need to be sent to you by the end of this week, if possible?
If possible, yes. We've got a little bit of time. The timeline for getting the accessibility test for the site is a little bit farther out than we had hoped it might be. So that is obviously not going to, we don't need it until we get to that point, which is looking like early November right now. But yeah, if you can send that to Jessica and copy me on it, we'd love to get those made as soon as you've got time to send them to us.
Okay, awesome. Thank you so much.
Yeah.
Daniel, I know that we're running out of time. Can I just say one thing?
Yeah, please do, Ernie.
Good morning, everyone. I in the last 2 weeks, I received 3 calls from individuals that are suffering with eye loss and they're based out of North Carolina. Two of the ladies actually just moved into North Carolina area. Whitset, I think is the name of it. My question to any of you here inside the Alliance, if you have any sister agencies in North Carolina that you may be able to send me through email, I would appreciate it because I like to send it to them. They have no idea who to reach out to receive services. Also, one of the ladies has a vision and hearing impairment, and she is trying to get information about hearing aids. So right now they're just, you know, kind of in limbo, and it was just amazing that it's, you know, 3 people, all of them is in North Carolina, you know. So I'm trying to do research to see if there's another organization like the commission in North Carolina. I know there is in New York. I know about the New York stuff, but I don't know anything about North Carolina.
Yeah, would anybody like to share North Carolina resources they might be aware of?
Hi, this is Darlene. We can certainly look up the phone number for you or get it for you and send that out.
Okay.
But every state has a vocational rehabilitation agency and a commission for the blind. And some states it might have a different name, but each state does have that resource available. Some states it's combined, some states it's separate, like here in South Carolina.
Okay, so I'll look into those under voc rehab. I didn't think to look into voc rehab. I just punched in commission, and I also was looking for agencies that is similar to association and anybody that can be able to guide them into training and things in that nature. So yeah, if anybody has it, please feel free to email me anything so I can be able to pass it on to them. I appreciate it.
Carol, do you have the contact information for the blind agency in North Carolina? If not, we can surely get it. Oh, maybe she stepped away. We'll get it.
Daniel,
Yes.
this is Tammy. North Carolina also has the North Carolina Assistive Technology Program. All states have those programs as well. And they are set up a little bit different than we are. I don't think all their services are free, but that could also be a resource for all 3 of those people.
The North Carolina Assistive Technology Program.
Technology program.
Okay.
And Carol, thank you for putting the link to that North Carolina voc rehab facility in the chat as well.
You're welcome.
Thank you.
And Ernie, there are a couple of Lions groups in North Carolina too. I'll call you after this meeting and get a little bit more information from you to see if that might help. But there are some Lions folks up there too that might be of assistance.
It sounds great. Thank you so much.
Yeah. That's what we're all about. Any other comments on the website? Any other resources that we should add? Any other changes that you see? These have all been very helpful suggestions. I really appreciate your time to help with this. Okay, not hearing anything else. I know we are a couple of minutes over time and I want to be respectful of everyone's schedules. I will send a survey out about speakers for next year. I'd love to get your feedback on what kind of speakers you would like for future programs. We've tried to do a balance of educational and health, as well as fundraising and marketing, and hearing directly from those that we're serving and impacting as well, while leaving some flexibility for important relevant issues that come up during the year that we need to address and hear more about. So please take a minute when you see that come through to respond to that survey. Did anybody have a problem with this year's general meeting schedule? We alternated kind of between Tuesday and Wednesday mornings, kind of around the 3rd or 4th week of the month. Did that general time frame seem to work? I'm preaching to the choir, obviously, because you all are here. Should be calling those that weren't, but that worked well for everyone. Okay,
Yes.
I'll propose some a calendar for next year's events as part of that survey, and feel free to provide feedback on that as well. If there's nothing else, I'll stay on for a little bit if anybody has other questions or things that they need to discuss or bring up, but we are 4 minutes over, so I appreciate everyone's time. Stay tuned for the recording from this, and we will see you all in the new year. Thank you all so much for what you do.
Thank you, Daniel. I did just want to throw out there that November is National Eye Donation Month. So Miracles in Sight is going to have a lot of posts on our social media about donor families and recipients and some like spirit days and things like that. So if y'all don't follow us already, if you would like to, it might be a great time to do that. We have some exciting content coming up, and a lot of outreach to our hospitals in South Carolina and that sort of thing. So I thought I would throw that out there, that y'all might appreciate participating, even virtually. So
Thank you, Abby. That would be great. Could you repeat it? It was National Eye
Donation Month.
Donation Month. Awesome.
Yeah.
Thank you. We will definitely share that information and support y'all in that. That's wonderful.
Great. Thank you. All right. Have a great day. Thank you.
Thanks, Abby. You too. All right. Thank you, everybody. We appreciate your time.